If you learned something today or you're reminded of something that you sort of have forgotten or you don't think everybody on your team is using, today's the day to make note of it, pull everybody together and say, hey, we all need to be calibrated on this. We all need to be a part of an oral pathology team. It's really common. I mean, just more and more tests are showing that men are highly infected. In fact, a recent study showed that 50% of the college males tested positive for HPV, and they highly suspected that the numbers were higher. The challenge, I think, is to educate our patients to be self-aware and to partner in their own oral health and safety.
Get ready for your unofficial dental hygiene podcast. These are the tales of two hygienists, one East Coast RDH and one West Coast hygienist. Listen as they tackle the profession of dental hygiene with humor and enthusiasm. Now, please join Michelle Strange and Andrew Johnston as they tell you a tale of two hygienists.
Welcome back, everyone, to another episode of A Tale of Two Hygienists, episode number 310. My name is Andrew.
And this is Michelle, your newly licensed hygienist in Colorado.
Yay! Hooray, Yay. Hooray! Good job, buddy.
Oh,
How was the process?
Thank you. So easy outside of me doing all of the paperwork, Colorado made it really easy once I got all my stuff. It was nice.
Man, we're not going to have a whole East Coast, West Coast battle again, but I'm telling you, I'm loving the West Coast, the way we do licensure.
Yeah, well, this is
Oregon,
one of many states, so I'll let you know how it all goes.
All right. So we did get a question. It's been a little while back, and I totally forgot about it until just this morning.
Okay.
So if you want to answer this before we throw to the episode, I think that'd be really good.
Oh, good. No heads up. Love it. Okay.
Yep. That's how I love to. I want to catch you off guard. No, it's an easy one. It was just tell us about your process before you're going into work. What do you do? I think it was mostly like headspace. Like, what do you do to mentally prepare for the day? And what do you do also, like, what are your physical, okay, I go get coffee. Well, you don't do that anymore. You do your mushroom garbage. But like, what were you doing, before the clinic day to make you prepared for it?
I definitely, my last clinic day started at 7 a.m. Like my first patient was like maybe 7:30. So I was there at 6:50-ish, probably depending on traffic. And I definitely sit in my car. I have done this every office I've ever worked in. I sit in my car for a solid 5 minutes.
Wow. What are you doing though? You just like listen to music? Are you thinking?
Listening to the last NPR interview, podcast, whatever, mentally gearing myself up to go in. But I could not go into a day, or I would not like to go into a day where I don't have the time to walk in and put my stuff down and set up my room and look at my day and make my notes on each and every chart so that I know who's going to need x-rays, who is going to need full mouth probing, who is going to need whatever. I need that. If I don't have that, I'm a very unhappy hygienist at the day.
Yeah, that's fair.
So yeah, I probably would do all those things, get all of my instruments ready. I like to prepare each one of my bundles, I guess. Make sure I have all of my disposables already pulled out. I have a mask set in each one. Anything I would need for that one patient gets put in a bundle with the instruments and kind of stacked. And I use the Zerk tray, so it kind of gets stacked put inside the tray and then stacked. And yeah, I would just prepare like that. Throughout the day, though, I will tell you, I stretch so much. Anytime the doctor, if the doctor looks over at me, he's probably like, Michelle, what are you doing? I'm using a door jamb, pulling my arm. I'm stretching my forearms. I'm doing something probably weird while he's doing the exam. And I'm just back there yeah, so Betty and I talked about using the new electric toothbrush we disclosed. I saw some, whatever. I'm over it. I'm giving them the 411 and I'm stretching.
I bet that's a sight to behold.
Multitasking at its best. Yeah. So I think that's it. Does that answer the question?
Yeah, no, I think that's good.
I'm trying to think what else. I was almost always the first person in an office. I'm trying to think if I was ever, I think just temping, maybe I wasn't the first person in the office. Maybe it's my outreach. Olga, the assistant, beat me to it because she was there, I swear to God, at 5 a.m. I don't even know, but she was there at the crack of dawn with chickens. But I was always the first person. And I loved walking into a quiet office, turning on all the lights, turning on the compressor, doing all like the ritual stuff, and just kind of being silent and getting my life together. Why are you looking at me like that?
I just look, I mean, I am fortunate that I don't think I was ever had to be the first one there. I mean, we all turn on the compressor, whoever walks down the hall first, but like it's a rare day that I've ever had to turn on a light in an operatory.
I could bet my entire life's income that was the truth.
I think your perception of me just strolling in just willy-nilly like 2 minutes before my first patient is not true either. I was prepared. I swear. I was really good. I just wasn't as on top of things as you are. I'd go in, we have 10 minutes, we're good.
We're good. 10 minutes. It gives me so much anxiety. 10 minutes. No.
Yeah, wow.
I would love to hear everybody else. It's like, send us a message in Instagram, like DM us and tell us what like your routine is. And if you're more like Andrew or more like me. I would love
I bet they're overwhelmingly a lot like me.
You think? Maybe.
Yeah.
But I also don't have kids to take to school and stuff. So, I mean, that factors in. But I've always had really early work mornings. Like I'd be in the parking lot at 6:45, 6:50.
Yeah. So we had a 7 a.m. start for many, many, many years. And that was the same thing. It's like, okay, I'll be there at 6:50. And that's when I get there. So cool.
Well, we're going to make this a short intro because I might let this episode go a little long.
Huh,
Shocker, I know, but it's on pathology. It's so good. It was an amazing recap, and I invited Nancy Dewhirst on. She did a great job of breaking it all down for us and kind of going back into like the basics, which, man, I needed. When you're not writing up charts, you don't use it, you lose it. And I was like, yeah, those words, I knew them once. Those are things that I know how to spell. Okay, I should start using those. So it was really great. And I think you guys are going to enjoy this episode with Nancy Dewhirst.
Before we get to the interview, we want to say a big thank you to Paradise Dental Technologies, or PDT, for supporting the continuing education portion of this podcast for so many years. If you do not know already, many of our full-length episodes count for CE. You'll find the links in the show notes, or you can sign up for our newsletter by going to taleoftwohygienists.com. When you sign up for the newsletter, we will periodically send out links to shows that have expiring CE courses attached. And none of this could be possible without the support of the amazing people over at PDT. So check out their hygiene and other instruments at pdtdental.com. That's pdtdental.com. Now, on to the interview.
Well, listeners, welcome to the interview portion of the podcast. I cannot believe after almost 7 years, we are having our first pathology podcast. I am ashamed to say that, but it took a minute to find a fabulous speaker to bring this knowledge to us today. So I want to welcome Nancy Dewhirst to the podcast. Welcome.
Thank you. Hi, everybody.
It was great to have you here. Nancy, I would love for you to tell us a little bit about who you are and what you're doing these days.
Well, I am a dental hygienist. I just don't practice, not for a long time. I teach at West Coast University. I'm adjunct faculty there, but most of my time is spent giving continuing education courses. And of course, with COVID, my biggest concentration of courses has been on infection control, emerging diseases, COVID, all of that, but a little bit on ergonomics, pathology, disaster preparedness, which is all too timely, I'm afraid. So that's kind of what I've been doing, mostly from home, but we're just starting to break out and have in-person presentations, and that's kind of scary and kind of a thrill.
Yeah, it really is. I'm excited for it, but also, like you said, it's just a little, I'm like, wow, there's people around me and I don't know how to feel about it.
I know. We're all sort of, gosh, I have to wear something other than slippers. What do I do?
Yeah, well, I'm not okay with that in any way. Not okay with it. Well, I'm excited for this topic. Like I said, we haven't had a pathology course, so I'm really excited to kind of dive in to some of the foundational stuff. If this feels elementary for some, or I feel like a review is never a bad thing, but, I feel like I'm about to learn a lot or be reminded of a lot. So, like, where would you like to start with this?
Well, I like to start with the title. I kind of tongue-in-cheek called it Lesions and Lifestyles a long time ago, and it really sticks because sometimes the lesions we see are related to lifestyles, and it kind of reminds us to ask questions and to see everything in context of the person's life. So we're going to be concentrating on oral and pharyngeal pathology. Of course, in this short period, we can't go very deep, but we can do kind of a general overview and bring people back to what they need to remember. Sometimes we've learned it all, but gratefully, we don't run into cases that are extreme very often. So this is about finding the subtle ones early enough to really make a difference in the person's life.
Mm. And so, like, where do we start with? I mean, I love this title, Lesions and Lifestyles. It's so perfect. So where do we start with in our pathology knowledge?
Well, you know what? I think this is about calibrating the team. Maybe one person in an office situation knows a lot about it, but sometimes a lot of other people don't speak the same language, haven't seen it as much, and we are as good as our team. So a day like today where we're reviewing, in this case, some really basic information, it's about calibrating everybody together so they can communicate and we can work seamlessly together.
Mm. And what does calibration look like? What does a team look like that's calibrated?
Well, it comes down to having a system in place and having the whole office know that we're committed to early detection and we have technology available or systems available. We communicate as a team about it and we use similar technical terms to communicate with each other and with our referring specialists. So that's kind of what it is. It's just making sure that if you learned something today or you're reminded of something that you sort of have forgotten or you don't think everybody on your team is using, today's the day to make note of it, pull everybody together and say, hey, we all need to be calibrated on this. We all need to be a part of an oral pathology team, as well as providing regular dentistry that we do every day.
I love that. And then take this podcast to your team and they can listen and learn all the cool things that you're about to learn and then go take all of Nancy's courses.
Well, let's just start with this one. So I think early detection is essential. It's the most important thing. Oral cancer is 3 times more common than cervical cancer with twice the number of deaths. Why is this? This is because people know about cervical cancer exams. They get exams frequently. The public is educated and aware. And this is our chance to learn and remind ourselves how much we already know and to educate the public about oropharyngeal cancer because it's more prevalent than melanoma or Hodgkin lymphoma, but people don't know about it. Routine exams are vital, so let's start there. Let's make sure that every patient that needs to be examined is actually examined and make sure that we educate our patients so they can invest in their own health, become self-aware. They can actually self-assess Total success here is when you educate your patients to the point where they come to you and say, I think this is not normal. Boy, when you've done that, you have an educated patient base.
Oh, God, and that could go across the whole gamut of oral health, right?
Right,
if we could just
exactly.
teach them all of the, like, come back and tell me what's not right here. That would be a dream. So I know you kind of touched on it, but like really when we think about it, how big of a problem is oral and oropharyngeal cancer?
Well, you know what? It accounts for about over 3% of all new cancers and about 2% of all cancer deaths. That doesn't sound like a lot, but it's a very small part of the body. And unfortunately, those cases are growing in some populations. So case distribution shows that it's more common, twice as common in males than females. Racial distribution seems so far to be similar, although there are new statistics that may give us a better insight into that distribution. In recent years, for both men and women, there's been a decrease in HPV negative oral and oropharyngeal cancer and a rise in those cancers that have an HPV cause. The average age of diagnosis is about 62 years old, and over 25% of the patients are under 55. Death rates have been decreasing over the last 30 years, thank heaven, so we're doing something right. We're catching some of them. Oral and oropharyngeal cancer patients have an increased risk of other related lesions, so they have to have more screening, ongoing screening, basically lifelong dedication to cancer detection once they've had any cancers.
Wow. And what are some of the common risk factors that we would see with our patients?
Well, smoking and alcohol, or any nicotine use and alcohol, are at the top of the list for oral cancers, those in the mouth. HPV is also a risk. Chemical and physical trauma can be a risk. Being immunodeficient, inherited disorders like Addison's, and iron deficiency anemia, of all things. Those are recognized risks for oral cancer. Tobacco and alcohol, as I said, are the highest on the list. They're involved with 80% of the cases, and they have a synergistic effect. Alcohol alone increases your risk up to 2 times. Smoking, say 2 packs a day, increases your risk 5 times because cigarettes have more than 70 cancer-causing chemicals. Smoking and heavy drinking together, however, that's it. That increases your risk to 15 times what it would be if you did neither. Being in a low socioeconomic category also increases your risks for so many reasons, like poor access to care, poor nutrition, that kind of thing. For instance, just an example, I just want to, have everybody kind of reflect back on your daily practice. If you have smokers in your practice, you see nicotine stomatitis all the time, to the point where you kind of don't pay attention so much because it's so common with smokers. And it is only a moderate cancer risk until it's not. And so you always look. You see the leukoplakia, you see the stoma, the opening to the salivary glands on the palate, but look for any arithmetic areas of different change, because even nicotine stomatitis can lead to cancer. And vaping is, of course, a little bit newer. Thousands of patients are treated for vaping lung injuries. There are hundreds of fatal cases. So we know about e-cigarette use. Most of us are highly aware of this. And we're also aware of vape-associated lung injuries, or E-valley. So vitamin E acetate is found in all the lung samples of these cases, and it's thick and sticky, It's considered an important cause of vaping damage. Sometimes it's used by illicit sellers to cut or dilute THC and to increase their profits. Most cases, the users will combine nicotine with THC products. The lung damage is similar to what one might see with exposures to toxic chemical fumes, poisonous gases, and toxic agents. So bronchiolitis obliterans, this is linked to vaping, and this is the lung damage that most of us are aware of. Scarring of the bronchioles and alveoli is what happens here, and it leads to something called what you might have heard referred to as popcorn lung. It's diacetyl butter flavoring that causes this. The FDA has recognized 19 chemicals as harmful tobacco products, and those now include diacetyl. So the long-term effects of vaping, well, we actually don't know, but evidence is growing. The FDA does require manufacturers and importers to provide chemical information, including information about what happens when you heat the chemicals, but that's not always provided, not always easy to provide, or even easy to calculate. For example, vitamin E is okay to ingest, but it's dangerous to inhale. And the temperature that it's heated to makes a big difference in the damage it causes. The other problem is that FDA can do whatever they want, but people buy altered, unregulated devices and contents. And so the FDA has no control over what somebody conjures up in their basement. So it's a really hard thing for the government to manage for the public safety. E-cigarettes, however, don't produce the tar or the toxic gases that cigarettes do. Nicotines and flavorings are dissolved in propylene glycol and glycerol in these things. And then the e-liquid is superheated, and that's the thing that leads to the unknown risks, that combination and heating. The heating element, by the way, can also contribute lead and metals to the vapor, so it's coming from everywhere. Add that within the context of who is vaping, and teen lungs are not fully developed. They can be more vulnerable to heavy metals and to ultrafine toxic particles. Research shows that e-cigarettes have been promoted as smoking cessation tools. A lot of people think they're getting into it to do that, but then they're sort of afraid to stop and they become dual users. So e-cigarettes double the risk of heart attacks. And if you use e-cigarettes and cigarettes together, that increases the chance of a heart attack 5 times. So you can see what happens with the behavioral element in here. People kind of mix and match, and then they end up in real trouble. The other risks worth mentioning is smokeless tobacco that leads to tobacco keratosis that you see, tobacco pouch keratosis, you might call it. And that's usually leukoplakia. Sometimes it's corrugated, very thickened, and it's fine until it's not. And so again, look for any alteration, any arithmetic lesion on the surface of a patient with that condition. So the differential diagnosis, when you see something like that, maybe it's plaque type lichen planus, white sponge nevus, chronic hyperplastic candidiasis, cinnamon oil allergies, smoking related leukoplakia, or just plain smokeless tobacco keratosis. So it's up to us to refresh our memory on all the characteristic conditions that could be confused with the thing that's sitting right in front of us. We don't want to jump to conclusions. We want to consider it all. So if it is tobacco keratosis, that's typically reversible until it's not, and until squamous cell carcinoma develops, which is a potential risk. Another one worth mentioning here, just understanding lifestyles in our country that are changing, beetle nut chewing. This is something that is used in Southeast Asia and India, Middle East, and it's caused by areca nut or beetle quid chewing. It only has a 1% cancer risk. Most importantly, it results in increased keratinization and thickening connective tissue bands. It leads to oral submucous fibrosis. And chronic beetle quid use leads to the development of firm banding. And that can be really painful. And the most important thing is you lose elasticity of tissue that needs to be movable, like your soft palate. Even your mandible opening is decreased. And of course, there is that small chance that it can lead to carcinoma. So I think the message here is to think about your patients and ask yourself if you know what their risks are. And the next most important question, do they understand their risks? One thing you can do is do online cancer risk assessment. And Philips has a tool for this, and you can do it with your patient. That really helps with patient education. Why do you do this? Because it sets up your oral pathology screening exam recall, and it justifies your screening cost and the need for screening, and that's something that's helpful in justifying costs for insurance coverage. It increases the patient education and certainly helps with legal liability by recording the fact that you not only just did a screening on your own, but you recorded it and you have a record of that. So you go to the Philips site, you select oral pathology assessment among their various types of oral assessments that are possible. And then you're going to ask the patient about 23 questions. So basically you're going to cover cancer history, radiation therapy, the presence of leukoplakia or erythroplakia that you've noticed, a non-healing ulcer, swelling, numbness, tingling, difficulty swallowing or chewing, sore throat, hoarseness, non-painful enlargement, lichen planus, because remember, patients with lichen planus, particularly erosive lichen planus, have a greater potential for cancerous change. Alcohol and tobacco use, beetle nut, quid, areca nut use, immune suppression, other things like sunburns, poor nutrition, HPV infection, and age. These characteristics help you establish the patient's risk, and you must do it with your patient so that they can give you the information you need to fill out the questionnaire, and so they learn what the risks are.
And then hopefully they come back and say, hey, this is not right. Can you check this? Like we talked about.
Exactly.
What a dream.
Exactly.
And so I'm assuming, am I assuming correctly that we should be examining everybody? And like when we examine, what are we looking for exactly?
Good question. Yeah, everybody should be assessed, especially those with higher risk. So we want to think about what we're doing already. All of us out there are doing some level of assessment. And the big question is, are you consistent? Are you doing it on everybody? Obviously, we have limitations of time and all kinds of things can affect this. But ask yourself, are we doing a visual exam? Are we palpating? Are we interviewing the patient? Do we make use of visualization technology like the light systems that are in place? Do we biopsy in our office or do we refer for that? Do we do salivary or tissue HPV tests in our office? And do we do a risk assessment? It's important for us. And just remember, we were talking about cancer, but every time we assess a patient, we're looking for anything that's atypical, and it's not all cancer. So we have kind of a list that goes through our mind when we see something, and we look at the possibilities, and very quickly we kind of screen through them, and we say, is this just a variant of normal? Or was it an injury? Or was it an inherited condition? Or a reactive lesion? Is this infectious? Is it a feature of a systemic condition? Is this the tip of the iceberg? Is it a neoplasm? Now, neoplasm was last because, thank heavens, it's the least common. You're usually going to find a variation of normal or an injury or inflammation, maybe an infection. And also remember that whatever we see today at 5 o'clock or 3 o'clock is just a moment in time. Remember, diseases and conditions undergo a pathway, a pathogenesis, and we may be seeing them in their infancy. We may be seeing them in a healing stage. Should we assess this in 2 weeks? And what will happen if we wait 2 weeks? So this is what goes through our mind every time we see anything. And so let's talk about where we're going to be looking. It's really important. Location, location, location. Very important. And we're talking today about oral versus oropharyngeal cancer. And oral is, of course, where we work all day, every day. And then the pharyngeal area is back further, right? Further on the tongue behind the circumvallate papillae. And both areas cross over right at the tonsillar pillar and include the tonsils, not the tonsillers, the tonsils, and the soft palate and the uvula. And so this area kind of comes together at a point. Unfortunately, for most of us, that point is the demarcation of where we can accurately see and assess. So let's look at the most common sites for oral and oropharyngeal cancer. The highest risk are the tongue, the tonsils, and the oropharynx. Next is the floor of the mouth, the gingiva, and other areas. And the least risky are the lips and the salivary glands. So for cancer, that's true. So we want to remember that the most common oral cancer is epithelium-based and is squamous cell carcinoma. And it's called the Great Pretender. Remember that from school? That's because of its widely varied presentations, right? It can look so many different ways and trick us. It can be red, it can be velvety, it can be presented as leukoplakia or speckled or erythroplakia. It can be verrucal, it can be exophytic, it can be indurated. It can be so many different things. So the early signs of oral cancer, we can see indurated nodules or masses. We can see something like an extraction site that doesn't heal right. And we all learned that in school, but boy, when you see it, it pops up and you go, I remember that. This is not good. This is either an infection or something else was causing the need to extract that tooth, right? It can be, it can be an ulcer that doesn't heal or that persists longer than 2 weeks. Now, that doesn't always mean it's cancer, but boy, that means we need to evaluate it. So the oropharynx is this difficult to assess area. And I want everybody to think about your systems when you're working. If you see something in that area or in the mouth or anywhere, who do you refer to? We typically refer to the oral surgeon, right? Well, they can't look down the throat. They don't. We need to be referring to ENT specialists as well because this whole area that is growing in importance for cancer risk, especially related to HPV infection, is an area that we can't visualize. And that is a major shortcoming in our diagnosis. There's also something that we need to remember. It's tonsil grading. We should be looking at tonsils. They're a very high risk area for cancer, so we need to be accurately describing what we see. Number one, we have to look. Number two, we have to describe that, and then we need to talk with our patients so they can report back to us and tell us what the history of this is, how this goes. Does it come and go? Is it growing more and more? So grade 0 is tonsils are gone, they were removed. Grade 1, tonsils are behind the tonsillar pillars. Grade 2, tonsils are enlarged up to the tonsillar pillars. Grade 3, the tonsillar enlargement is visible beyond the pillars. And grade 4, you're having trouble breathing and swallowing. It goes way back there, it's closing things up. So that's serious. And the patient usually notices that, right? They're going to be talking about that. Other early signs of oral and oropharyngeal cancer, a painless neck mass. This is the most common. A white or red patch, a sore or an irritation or a lump or a thickening, difficulty in chewing and swallowing, ear pain, or difficulty moving the tongue or the jaw. Hoarseness, or a sore throat, the feeling that something's caught in your throat, numbness in the tongue or other areas, and sometimes it's tingling, and sometimes the patient just says it feels funny. So when I interview the patient, I always ask, is anything odd? Does anything feel different? Have you noticed recently that you remember? And sometimes this kind of a paresthesia or odd feeling will come up. Any swelling of the jaw that causes the dentures to fit poorly or become uncomfortable. Now, that we know, that's pretty understandable to all of us, but we have to tell our patients. So we observe gross tissue, that's visible. But you know what? You and I need to be thinking and visualizing all of this at the cellular level. Our job is to understand, describe, and explain both. And by taking our minds to the cellular level, we can more accurately be aware of and assess what's happening at the gross level. So remember, squamous cell carcinoma is the most common oral cancer. Remember this, and you can use this to explain the signs and symptoms that you're seeing to the patient, that skin reacts normally to use and trauma with 3 activities. It creates more cells, hyperplasia. It develops more keratin, makes calluses, and it creates more melanin, as in tanning. That's what skin is hardwired to do. Neoplastic tissue displays this in exaggerated form. So you'll get hyperplasia, you'll get callus formation on mucosal tissue that typically doesn't make calluses. Okay, that represents a cellular change. And you know what calluses look like when they're wet. They look white. There you have it. And the cells in neoplasms are permanently altered. Remember that tumors need a blood supply, so they'll hijack the blood supply and you get greater vascularity around a neoplastic growth. So when we see something, when we're looking for something, in our minds we think, now these things start out with one cell, then hyperplasia gets going and more cells develop. Then these cells become dysplastic, and this is all pre-cancer. But at some magical moment, the cell change becomes permanent and it crosses a line, and you've got carcinoma in situ. Now, if you ever have carcinoma and it's diagnosed, you want them to find it in situ because it hasn't left its original location. And in squamous cell carcinoma, that means it hasn't penetrated the basal layer and gone on and started traveling through the main corridors of travel in our body, the lymph system, or the blood supply. Unfortunately, by the time the lesion is visible to us with our naked eye or even our loupes, it's already grown inward and taken a trip through the body. So that's what we want to avoid. How can we do that? We do that by using some of the technology available to us that focuses on different cell characteristics that can illuminate the presence of some of these cells before they turn into something bigger. So this technology utilizes fluorescent light. You may be aware of some of these lights, like Velscope is an example, Oral ID. There's some different products that you shine on the tissue and it reflects light back to your eyes differently based on the nature of the tissue, whether that tissue is absorbing the light or whether it reflects it back to you. So what cells absorb the light? What things look dark to us because the light was captured and not reflected back to us? 3 things. Chromatin. These are heavy molecules that exist in the cell nucleus, and you're going to find a lot of chromatin in cells that are rapidly dividing, as in dysplasia or malignancy. The other heavy molecule is melanin, and that is going to be found in moles and freckles and pigmentation and melanoma. The other, third heavy molecule is hemoglobin, and of course we find that in blood. So the lights will reveal the presence of blood vessels and inflammation and increased vascularity around a neoplasm. You can blanch the tissue to rule out blood or hemoglobin. So the blue light also works on outer facial tissue, even though most of them aren't FDA cleared for that use. You can sort of wander off out of the mouth onto the skin to the delight of your patients if you find something for them. And you can find things. So the blue light will show up hidden lesions that are not visible to your eye. You'll see a dark spot that you can't see with your naked eye. Or they will reveal a varied border, something that's different than what you can see with your eye. For an example, you see a scaly surface alteration, but then you shine the light on it and there's a larger, darker area. Well, what does that mean? It could be that was an inflammation or an injury. It could be chronic or acute. You can blanch it. You can kind of evaluate it. It also could reveal chromatin, atypical cells, kind of pointing you towards cancerous potential. This could reveal squamous cell carcinoma, basal cell carcinoma, or a melanoma. Now, the blue light is not going to diagnose it. It's only going to tell you where to look. So pharyngeal cancer is deeper. It's more hidden. And it can be caused by the same risks as oral cancer, but more often it's related to human papilloma virus. And this is the most common sexually transmitted disease in the US. There are over 150 types, but about 40 or a little over are found in the mouth. HPV infects only epithelium, and mucosal HPV types do not grow on the skin, but skin types can grow on mucosal tissue. So there are low-risk types, and these cause benign papillary oral warts, as we all know. If you have a persistent high-risk HPV, they cause the oral cancer. So detection is important. Our professional knowledge is vital, and public awareness is really important for prevention and for self-diagnosis. Let's break it down. HPV in females, 80% of the women are exposed to HPV in their lives. Just about 4% have oral HPV infection, and that's more common with age. Cervical cancer is the most common HPV-related cancer in women, and HPV causes most cervical and vaginal cancer, so it is the most common cause. Age and vaccination status will affect our risk, of course, and the type that we're infected with is going to greatly determine our risk for cancer change.
So, is there a test for HPV, and should we be testing for it?
There are. Let me give you some context. Cytology, or a pap smear, is the most common low-cost test for cancer, as we all know. It detects 55% of high-grade precancerous lesions. It reveals pre- and cancerous cells that are either HPV related or not, and we should be tested every 3 years for that. That's what the public knows. That's what we know. HPV DNA tests are something different. They detect 14 high-risk strains. They cost more money, and they detect 96% of the high-grade precancerous lesions. They reveal the presence of HPV, but they're site-specific, so they're limited to accessible tissue, and of course they only test for HPV, and they would miss a cancer that was caused by something else. Cytology plus DNA analysis, co-testing, is the most reliable, and if people are undergoing both types of tests, then they can be tested at longer intervals every 5 years. There is no overall test for your HPV status.
So are those the best ways to detect HPV, and are there any ways for us to prevent it right now?
Yes, there are. Let's look at, now we're going to look at men and women together. That's the answer for prevention there. Oropharyngeal HPV-related cancer is increasing in men. The highest risk for men is being HIV positive and men who have sex with men. Vaccines for males ages 9 to 45 are not approved to prevent penile or pharyngeal cancer, but research does support those claims. It's really common. I mean, just more and more tests are showing that men are highly infected. In fact, a recent study showed that 50% of the college males tested positive for HPV, and they highly suspected that the numbers were higher. So there's no treatment for infection, really. You can treat the cell changes due to the infection. For example, if you have warts, you can surgically remove them, or in some cases remove them with medication. Precancer and cancer, you remove with surgery, radiation, chemotherapy. The vaccine prevents, but it doesn't treat the infection. So HPV-related lesions, the oral prevalence is about 7%. Most infections are cleared from the body within about a year without causing any cell changes. That's good to know. Some infections last for about 20 months with no clinical signs, and some appear to be cleared, but then they come back, or they were dormant and hiding and we didn't know. They can progress, alter cells' DNA, and cause dysplasia or cancer. So how is it transmitted? By direct contact. HPV must infect basal epithelial cells. That means it usually requires a break in the skin, tearing, chafing, skin injury. Even with intact mucosa, though, there have been cases of transmission. So it doesn't always require a break, but usually damaged tissue. The pathogenesis is that it proliferates from the basal cells. HPV inserts itself into the nuclear material of epithelial cells. It alters them, and that is visible microscopically.
So I know you mentioned, what was it, like 40 more than 40 types of HPV that we can find in the mouth. So is there some more information about the various types of HPV that we should know about?
Yes. Generally, when you think about how HPV is recognized, say you take a biopsy, and we'll start here. You send it to the pathologist. There are cells called coleocytes, and these are HPV infected cells. If you don't do any other analysis and you just look at them under the microscope, they're recognizable to a pathologist. They have irregular shaped nuclei and a clear halo in the cytoplasm. That generated a name for the tissue. They called them coleocytic dysplasia, but they've changed the name, which is more reflective of the cancerous potential of this tissue. They call it now HPV-associated oral intraepithelial neoplasia, because they couldn't come up with a shorter term.
Like, geez, what a mouthful.
I know. So the definitive diagnosis, the gold standard, has always been microscopic, but to your question about the different types, we now need to do molecular analysis to know what we're actually dealing with. So the different types have different cancerous potential. So the low risk, not no risk, but the lower risk types are 6 and 11, and they're associated with benign warts. That would be papillomas, verruca vulgaris, which is a common dermal wart, condyloma acuminatum, the genital warts, and multifocal epithelial hyperplasia, Heck disease. Am I bringing back some memories from your pathology class? Remember these words?
I remembered everything up until Heck, and now I'm like, oh my God, did I forget that? Completely space on that?
Oh, heck, I forgot heck. All right.
Yeah. Oh, heck.
Oh, heck. Okay, so then there's the high-risk types. This is what we really want to home in on, because this is HPV 16, 18, 31, 45. These are the main ones that cause cancer, and they're not as easy to find because they cause flat, non or hardly visible dysplastic lesions that are basically squamous cell carcinoma. Not as easy to find as a big wart. 16 and 18 cause about 95% of the cervical cancer. And now these two types are associated with most of the oropharyngeal cancer. Viral particles are identified by immunologic staining. And a key thing here is where you're going to find them. And in the oropharynx, the highest risk spot are the tonsils. Oh. So tonsillar cancer risk factors. 24% of the U.S. is chronically infected with high-risk HPV. That's not the majority. It's only 24% before you hyperventilate, but it is something. 90% of the oral pathology cases are HPV positive, and the incidence is increasing. Here's the kicker. Lymph node metastasis at the presentation is 80 to 85%. You know what I'm telling you? We're not catching it early enough. Now, smoking is related to over half the cases. Alcohol doesn't seem to be a significant factor. And as to how do you get it, sexual history is strongly related to the risk. Interestingly, marijuana increases risk, and I hypothesize that you have more sex. That's my thought. I have no idea. All right, so oral tonsillar cancer that is not HPV related is becoming more rare. So non-HPV cases are only 10%. Smoking is related then to about 90% of those cases because it's not HPV. Alcohol has a synergistic effect, like we said. Sexual history seems unrelated, and it has 3 to 5 times higher mortality than HPV-related cancer. So here's the trend. More HPV cancer, and it's not quite as deadly. So that's kind of good. Let's compare them. HPV negative cancers. These mean cancers that are not caused by HPV. They're decreasing. They hit older patients, typically lower socioeconomic status. The risk for those, again, is going to be alcohol and tobacco mostly. And they have a very poor survival prognosis, about 40% 3-year survival. The HPV positive cases, they're increasing. They're hitting younger patients. They're higher socioeconomic status. The risk is sexual history, and luckily they have a better prognosis, 80% survival at 3 years. And smoking and tobacco, if you engage in those with that negates all the statistical benefits of being an HPV positive cancer, because now you're mixing risk factors, right? So you can develop cancer. Those cells are being challenged by different factors. HPV transmission, again, is sexual, oral, genital contact, and that includes deep kissing. Rarely it's transmitted vertically from mother to child, and it has been recorded as transmitted from parents to child, and they think maybe it's saliva. So the duration of HPV infection is important, because remember we said a lot of people just develop it and it goes away. They're transient carriers. They have no lesions, the infection clears, but they'll have a positive serum antibody. The chronic carriers, commonly associated with cancer, and they would have the highest risk. They're also commonly associated with people that are immunosuppressed, and that tells you kind of the story of what's going on here. This is an infection. If you're immunosuppressed, it wins. If you're immunocompetent, you may win. So that's good.
That is good. So we've we understand, like, if we see something, we got to say something. We got to document it. We got to write it down. But how does HPV actually get diagnosed?
Well, cytology and histology is sort of the pap smear, we said, is less predictive of HPV-related cancer than molecular HPV testing. Oral exfoliative cytology or rinsing could miss HPV-infected cells that are located out of its touch, and those might be the ones that would be within the crypts of the tonsils, which is very commonplace for them, or deep in the throat. So that's the limitation of those processes. Molecular testing detects the persistence of high-risk HPV, and HPV DNA expression plus some other detection tests that detect the proteins that are emitted by both the host and the virus. Those things can tell you what the virus is doing, and they indicate pathogenesis. So there are sophisticated tests for analyzing not just the presence of HPV, but what it's doing and the body's reaction to that. So again, the transient carrier, which is the most common, in that case, the virus would usually clear in 1 to 3 years. You would detect the presence in the mucosa by in situ hybridization, PCR test, and antibody status. A chronic carrier, which luckily is less common, if a high-risk HPV type persists, it's more likely to progress. So we can detect that by antibody status, molecular testing, and repeating that at short intervals. Once you know what kind you have, that tells you how often you have to be tested. The DNA probe can include transitory HPV infections. So people get all worried when they have a DNA test, and most of the time, it goes away. So truly you need both. You need evidence of HPV DNA, and then you need evidence that the viral DNA is being integrated into the host cells, and that's a test called P16+. So you're testing for a marker called P16. So these are things that somebody else is going to do, not us, but we need to be aware that there's this sort of multifactorial testing. For example, if you have a tumor in the oral cavity, saliva testing is very effective. If you have a tumor in the oropharynx, you'd be better off testing blood plasma for that. If you have a tumor in the larynx, they're very similar. Saliva and plasma tests should both be done. And if you have something in the hypopharynx, you need a plasma test. So what does that tell you? We need to be testing both things. Some subtypes are not included in the vaccine, by the way. The long-term immunity is still unknown, but for the vaccine, we know it prevents cervical cancer, and it's approved for males and females, and it does prevent STDs and cancer, and it may prevent oropharyngeal tonsillar cancer. So it's not a sure thing, but we like it for its potential help. So there are 2 vaccines, just quick reminders, stepping back from all this. Two vaccines prevent cancer, HPV, hepatitis B, and HPV prevents squamous cell carcinoma. And on a happier note, current research looks at oral fluid diagnostics, point of care nanosensor tests for oral salivary biomarkers that would tell you if you've got oral cancer, and improved molecular testing. So those of you that are out there actively practicing, hopefully in the near future, you'll be using these technologies, and they'll make us a lot smarter and point us exactly to where we need to go.
Oh, that's nice to hear. And yeah. I've had some arguments in the last year and a half, last year, especially around the COVID vaccine, when people just do not want to take it. They have their reasons, and they'll say, I'll take it when we have a vaccine for cancer. And I was like, well, actually.
Yeah, we have to.
Yeah. So surprise, go get your shot.
Yeah,
get your injection.
That's what I think.
And I know, so we've talked a lot about what could happen when we find these things. It could be cancer, it could be different lesions. But what are some of the most important things to remember about our oral exams?
Well, I think just plainly put, look, feel, ask, and explain. It's our duty to do all these things. So we need to do the extraoral and the intraoral exam. So look for symmetry. Look for function. Have the patient move. Ask the patient what they feel, and ask about the history of anything that you come across. Look for lymph nodes and salivary glands and tell them you're doing that. We're looking for cysts. We're looking for infections. And yes, we're looking for dysplasia and neoplasms. But the large percentage of what we find are not going to be those last 2 things. So refresh your memory about the anatomy of the head and neck. Make sure you know where all the lymph nodes are. For example, the preauricular, the postauricular, the tonsillar nodes, the occipital nodes, the superficial cervical nodes, the submandibular nodes, submental nodes. Remember all those? We want to be accurate about it, and we want to be able to name them. And sometimes it helps to have charts that prompt us, right? So looking at the lips, look for trauma and scars, infections, blocked ducts, cysts, subsurface tumors, either of epithelial or salivary gland origin. Look for dysplasia and cancer. One feature to look for is the loss of the vermilion border. We know that makes a difference. So we're going to do an intraoral exam, and the important thing is to not miss anything. Labial mucosa, pull out the lips, move them around. Don't just look, feel them. Look at the obvious stuff like buccal mucosa. Look and feel, and trap it between 2 fingers, a finger and a thumb, and roll it. Don't tap it. Don't just touch it. Roll it. Roll the tissue between your fingers and your thumb. You're going to find things you'll miss otherwise. Look at the gingiva all around and stick your finger in there and feel the whole arch, right? the lingual and the facial, feel it all. And the tongue, oh my gosh, you're going to have the patient stick it out. Watch how it moves, left, right, and then we're going to do it ourselves. You're going to grab that gauze and put it on the tongue. Man, they love that when you do it, right? So you might want to wet
They
it
never
first.
gag. It's totally
I know,
fine.
they literally. I like to wet it first. It makes it a little bit less awful for them. But
Yes.
pull that tongue out, pull it to the side, and don't just touch it, but roll and pull your hand along from way down at the base of the tongue, opposing one hand with the other hand, squeezing the tongue in between. Pull along the tongue. You have to feel, you have to look. Then take your hands off the tongue and ask what the patient felt, besides like they wanted to gag. Ask them if there was any pain or if they felt any pain, because it's not just what you feel, it's what they feel. Look for masses, look for a change in shape, something that's not normal. And then the ventral tongue and the floor of the mouth, and you've got to feel that too. You can't just look at it. The floor of the mouth, sweep your hand all the way around. We're looking at salivary glands. We're looking for masses. We're looking for something that just isn't right. The hard palate, you got to feel that too. Be quick, got to do it. And the oropharynx and soft palate, if you can feel it with a sweep of the hand, it's amazing how much you will find. Yeah, I know you got to be quick with that one, but you got to do it. And the oropharynx, there's a trick. You want to have the patient actually tell them what you want. I want to look at the back of your throat. I want you to drop your tongue so I can see back there. Instead of sticking a mirror on it and doing it forcefully, which they're going to fight, right? They're going to fight back at you. You can just tell them to do it. And sometimes if you say, open your mouth, drop your tongue down, the back of your tongue down so I can see the back of your throat, breathe in. And if you have them breathe in and do that, you can see the back of their throat. And that is golden. You can see so much more if they let you. So good luck with that. So you try that. So anyway, again, touch everything that you can. Don't just look. And now the most important thing is writing down what you just did, recording and communicating abnormalities. Really quick, not to insult anybody because I know you know this stuff, but let's go over some basic terms and charting, because we just want to make sure these terms are used correctly and that everybody in your office knows them. So you're looking for things like papillary lesions, red and white lesions, masses, ulcerations, surface alterations. You're going to record the appearance and presentation. You're going to record a differential diagnosis, what you think, top 3 things it could be. And then eventually, that's going to give the information to the people who are going to give you the definitive diagnosis. So what do you look for? First thing you look for is tissue loss. If somebody loses tissue, why did it happen? Is it atrophy? Is it wear or trauma? Is the epithelium intact? You're going to look for tissue expansion. It got bigger. So what is that? Is it swelling or edema? Is it hyperplasia, hypertrophy? Those 2 things are cellular diagnosis. We don't know that, but you know what? We can give them a lot of information that will inform their diagnosis. And tissue change or alteration. So these are the things we're looking for. And then we have to describe it. I always have my perio probe there because that's what I have at hand always. So you're going to look for clinical appearance, exact location, shape, borders, attachment, color, size, soft tissue consistency, surface texture and integrity, radiographic appearance if you take an X-ray, History. Ask the patient, how long has it been here? Is it always the same? Has it been steadily growing? Does it come and go? What do you think it is? Have you had other ones like it before? They can give you a lot of information. Any symptoms, how does it feel? Are those symptoms consistent? Use terms to get this information out of your patient. And I love having a form that prompts me with key terms. That calibrates all of the staff members who use this form, because they remember to write down size, shape, color, location, texture, density, attachment, duration, symptoms, diagnostic technology used, what my clinical impression was, what I think the differential diagnosis is, and then what I recommend. Do we biopsy? Do we get a second opinion? Do we wait 2 weeks? What are we going to do? So these kinds of forms that help us get through the process faster also calibrate everybody together so we have a consistency in our treatment. And then draw the lesion. And I know you're all thinking, but I take a photograph. Well, digital photographs can be lost or flipped. So you want to do everything you can to make sure you don't get the wrong side, you don't get the wrong place, that you kind of double on yourself. You describe it with words, you draw it, and you take a photo as well, right? And maybe x-rays. So some examples of things that you might identify, and you may want to look up in your lexicon book, right? A cyst, a fissure, a macule, a nodule, a papule, a polyp, a pustule, a vesicle, a wheal. Those are just surface alterations. Some of them have an enlargement. Some of them represent a loss of tissue like a fissure. So practice your terms. If you had something on the surface, it might be a macule or a plaque or a patch. Which term should you use? So ask yourself, what is a macule? Is it a flat area of a different color? Is it a flat, dark lesion? Is it a large, dark lesion? Is it a large, raised papule? It turns out it's a flat lesion of different color. The normal one is a freckle. That's a macule. And we all think of freckles as examples of macules, but they're not all black. They can be any color. They can be red or white. They're just a different color than the surrounding tissue, and they're flat, and they're usually less than 1 centimeter. A patch or a plaque is reserved for the larger lesions on tissue, and they may not actually be flat. So you note the depth, the attachment. Is it firmly attached, loosely attached, or is it loosely adherent? You look at the size, the shape, the borders, location, color, surface texture, the density and consistency and integrity of the tissue, and then you ask the history, and then you give your clinical impression. The color, is it erythematous or speckled or pink or blue or brown or black or white? And if it's leukoplakia, it's a white patch, but you also have to add in location, shape, size, texture. Is it exophytic? Use all your terms to describe it. And erythroplakia, red patch, same thing. It may not all be flat. Some areas may be flat, and there may be one area that's exophytic and sticking out. Speckled glucoplexia is the common term for mixed red and white, even if it's more red than white. They typically use the term speckled glucoplexia. And surface texture, you might use something like corrugated if it kind of undulates up and down, or fissured, as in fissured tongue. And you're thinking about white sponge nevus or something like that. And then other terms are smooth, rough, velvety, denuded, ulcerated. We all know the term papillary, as in denture stomatitis or inflammatory papillary hyperplasia.
Nancy, would you be able to give us an example of a description of like a lesion that we might all be really familiar with?
Sure. How about geographic tongue? We all
perfect.
see that. That's kind of not very scary. Benign migratory glossitis. So everybody picture one of your patients who has geographic tongue. And here is how you would actually describe it. Multiple confluent patches of smooth denuded mucosa on the dorsal and lateral tongue with distinct, well-circumscribed red borders surrounded with white raised thickened tissue. The denuded areas are sensitive to pH and spices. Or you could just say geographic tongue, but that's a lot of words, right? But you know, we internalize all that, but we know all that. And if called upon, we have to be able to give all that information. And also remember that there's geographic stomatitis, that condition is not limited to the tongue, and it can really be scary. If you see that red and white weird kind of lesion under the tongue or somewhere else, it really looks like cancer. But remember, if the person already has geographic tongue, and you probably know that if they're your patient, and then you see it somewhere else, it may be the same thing, but it may not. So what would you do? I would wait, see if it's the same way in a couple weeks. Geographic tongue moves and changes, right? Cancer isn't going to go away in 2 weeks. Right. It isn't going to, no, it's going to be there. So maybe waiting 2 weeks, maybe you're going to look at it and go, nope, can't stand it, can't wait 2 weeks. Somebody needs to weigh in on this. Second opinion, right? Somebody may want to biopsy that and confirm it. You would hate to miss cancer because somebody also had geographic tongue. So we have to think a lot about this all the time, right?
Yeah.
So if there's a tissue mass, feel it. If it's indurated, remember that term means hardened, or is it soft or is it firm? You also want to know, is it fixed or movable? Does it have distinct borders, diffuse borders? Is it on the tissue, in the tissue? Which tissue? Is it painful? And of course, what's the history? How long has it been there? And remember, if you find a nodule, it can be exophytic, sticking out, or endophytic, which means it's held within the tissue and it's not necessarily raised up. And we use the term papule, kind of synonymous with nodule. It's little and small, well circumscribed, usually less than a centimeter in diameter, and it's elevated or it protrudes. And so many different lesions can be called nodules or papules. But then there's lobules, and those things, the clinical appearance is described as lobule. It's a gross clinical description, and we would say it was lobulated, and it means it's a segment or a lobe that's part of the whole. Sometimes they fuse together. That should be compared with the word locule or a locular. You would look at an X-ray and say that's multilocular or unilocular. And it's also used by pathologists as a gross surgical description. But we typically, when we find clinical lesions of tissue, we use lobular. So small distinction. So if you saw an X-ray and there's a big radiolucency and it had kind of crazy borders and it looked like it was biting holes out of teeth and bone, you would say, I see a multilocular radiolucency with diffuse irregular borders, right? So that's typically a description. And always note how something is attached. So here's an example. Here's a little test. We all use the word sessile, and very many times people use it wrong. So what do you think sessile means? Firm, flat, indurated, broad-based, or something that's immovable or fixed? And the answer is broad-based, but most of us use this term as immovable or fixed. Now, I have to say, if something's super broad-based, it's usually kind of fixed. It's not flopping around a lot.
Right.
So the terms kind of go together, but strictly speaking, so you can speak the language with the pathologist or surgeon, it is broad-based, as opposed to pedunculated, which, as you know, is on a stalk, right? Like a mushroom, pedunculated. It's attached by a stem-like or a stalk base. And then you always want to record if it's solid or fluid-based. If it is fluid-based, then, that's a vesicle of some sort. So you'd record if it's firm or thickened or hard or soft or fluctuant. And when you see vesicles and ulcerations, remember, most of them are going to be injuries or infections. So you want to kind of tell as much as you can between one and the other. The most common are aphthous versus herpes. So you want to kind of know if there's a possibility that there's a virus present. That determines whether you should treat the patient and its potential for spreading. Ask the history. They typically know. If it's recurrent herpes, they've had it before. And you ask if the vesicle preceded the ulcer. So, okay, in summary, this was a basic review to calibrate our pathology team because early detection is vital, and we really want to do a good job. So we accomplish this by a detailed clinical exam, and we always have to consider the history and what the patient tells us, and that'll help us arrive at a differential diagnosis. We reviewed the terms to accurately describe, record, and communicate our findings. The challenge, I think, is to educate our patients to be self-aware and to partner in their own oral health and safety.
Wonderful information. Such a great review, even for me. There were some moments I was like, what did I need? Yep, that's it. That was it.
It's stuff we all know, but it's like having a fire drill because you don't have a fire every day, right? We know we don't, so we have to have that fire drill so we can kind of remember what we need to do and where to go. And this is like it too, except actually we need to do this on every single patient, so we need to get better and better and better at it.
Yeah. And I'm a huge fan of standard operating procedures. We talk about it a lot in the infection prevention space, just making sure that everybody's on the same page. And the whole time I'm like hearing this and like calibrating the team, it would be so nice if like what you're going to say, how you're going to describe it was written out for everyone. You had it in your operatory. And what a dream that would be if you had a temp come in, because I've been temping, and to know that's how you the office, even though it feels like it should be standardized across dentistry, but we know that's not always the reality. But like, wouldn't it be great to have something like that standardized in the op, ready for them to follow, so they can take care of your patients the way you want them to?
Well, we have at our school, we have this embedded in on the computer. So when you bring up somebody's records, you click on a form that you have to fill out, and it has the prompts in there. And that's been golden because, of course, it's good for students, but for all of us, it just reminds us every time you have checklists, you're reminded to do things, and it records that you did them. That is good on so many levels, and it applies to this as well. So having some kind of oral pathology exam form, whether it's on a computer or on a piece of paper, this will bring us all together, and really, I really think it ups our game and streamlines the healthcare of our patients.
Love it. Nancy, thank you so much for all of this. I would love to give out some information to the audience who is listening if they want to take more courses from you or find out where you'll be speaking. Do you have any information that you'd like to share, contact information, etc.?
I can just give them my website, and on there I think that it's not always up to date in terms of all my courses because they change so fast, but they can get an email to me there, or just even faster, let me just give you my email.
Perfect.
It's ND, my initials, at my name, Nancy Dewhirst, Nancydewhirst.com.
Perfect. That's
And
excellent.
And the website is just nancydewhirst.com. So they can find me either way, and mostly the website is just kind of not kept up, so they're not going to be able to find. I'm sorry. It's
the story of my life too. It's a lot of work, and you're busy creating amazing content, so it's all right. Well, thank you so much for your time today, Nancy. This was a fabulous course that you gave to us.
Well, it was my pleasure, and thanks for inviting me, and take care, everybody. Be well.